Otherwise, we have to do back. Are there any questions? Yes. I mean, what you are pointing out with the same locations is quite busy. But you said you go either with an exon 17, 18, exon 11, and 17, 18 mutation, and then you give what is it, the best solution. Replicating. But then you are not treating the exon 11 still continuously active. You are killing only one other drug, but you stop active.
Yeah, that's correct. But all the drugs mentioned here are very active in the baseline primary exon 11 mutation. Sunitinib is active in exon 11, regorafenib is active in exon 11, and ripretinib is active in exon 11. So the primary mutation, and again, that will stay there forever. It's never a change from primary to secondary. It's primary plus the secondary. The tumor will never lose the primary mutation. We sometimes get the question, there was no more exon 11. That is a technical problem and never true. The primary exon 11 will stay there forever. A secondary is in addition, never instead.
It's really what else to see if some guys know it. Yeah, it's the matter.
There are studies going on looking at that, yes. Also in the adjuvant situation. The idea is, but it's just an idea at the moment, taking a liquid biopsy after surgery and look whether there is still some mutant GIST DNA around. And if there is none, we could hopefully assume there are no tumor cells around anymore. Yeah, the idea is that after surgery in a localized GIST, we take a biopsy, a liquid biopsy, and if there is no tumor DNA there, then we do not need adjuvant therapy. And if there is tumor DNA there, we do need adjuvant therapy. But that's a very theoretical and unlikely ever becoming a standard.
Yeah, I would like to give a comment on that because this is the oncologist's dream, that you just throw blood and everything is clear. But this is not realistic, I think, because, especially in GIST, at least what I know, the rate of shedded tumor cells is much less than in other sarcomas. So it might be much easier to follow a synovial sarcoma, so a completely different tumor, due to the translocation the tumor has, than to follow a GIST in the blood. So we should not hope that one day every 4 weeks you go to your doctor, he takes the blood, makes the tests, and bam, tells you for the next 3 months you don't have to take any pills or take a little bit more or whatever. So it's just another step on a long way to an ideal treatment, and I think we are not there already.
Definitely not. Yeah, we fully agree. There is absolutely no.
There's another.
Exon 9 is a bit of a problem. The best drug in exon 9, again, seems to be sunitinib with respect to currently available drugs. Therefore, the primary exon 9 is excluded from these studies.
Any other questions?
I have a discussion point. We always had the discussion that the way people take the imatinib into the body through the stomach or resected stomach or no stomach anymore, and all the other factors influencing the trough level of imatinib in the blood, that this would be of importance. But still, nobody looks, I wouldn't say nobody looks for it, but it's not the routine to say, well, the first analysis I do if I have a new patient taking now imatinib is to measure the level of imatinib in the blood, depending on weight, height, sex, whatever. Because if I imagine some of the studies you showed were made in China, and I've been to China on Eastern and saw the people and they saw me and we saw the difference, size, height, all that. So this must lead to differences. And if you then have a Chinese trial with 1,000 Chinese people, I don't know whether this is comparable.
I know that this was engaged with them. He started doing Cambridge. Always
Once or repeatedly or how?
in Holland, they just do it routinely and they're happy.
Yeah, but only on onset when you treat, or every 4 weeks, or
Well, well, still, blood level testing is not considered standard of care. It's not considered standard of care. It can be done in the context of a clinical study. It can be a personal recommendation, but there is no clearly established algorithm how to handle the result of the blood testing.
I don't think so.
Wait a moment. What Eva said is absolutely correct, but the standard dose of imatinib covers the full range of patients. There are no data that 400 milligrams are not enough for a normal patient. So using 400 is in the safe level, even with a pure absorption, you are still in a safe inhibitory level. But some patients will be overdosed with 400 milligrams. The 1 meter 30 tiny 70-year-old Chinese or Japanese women. That is true. But what do you do if the patient has high toxicity? You lower the dose. I don't need a blood level to lower the dose if the patient cannot tolerate the standard dose.
treating until the person is feeling ill.
There are very conflicting results from blood level testing. Some say it works in this situation, others say in the same situation we find that it doesn't work at all. They do other tests, and the general overall comment is that blood level testing is not standardized. It does not really represent what's happening. Imatinib works in the interior of the cell. Blood level is in the blood. So whatever you measure in the blood does not necessarily reflect the amount of imatinib that's in the inside of the cell, but it needs to be in the inside of the cell. So if it cannot enter the cell, and there are a couple of mechanisms that either enhance or decrease the amount of imatinib entering the cell, you may have a lot of imatinib in the blood, but if it cannot enter the gist cell, it cannot work. So you have a high blood level, but it does not result in efficacy because it doesn't enter the cell. Therefore, I can only repeat, blood level testing is not a standard of care. It's not uniformly useful. The results are very conflicting, and therefore we strongly recommend not to routinely use it. 400 milligrams is enough for everybody, and if it's too toxic, you lower the dose. That's why we recommend seeing the patients not once every 3 months, but more frequent in the beginning. And if they show more side effects, then we reduce the dose. And that works excellently well.
When you were in China, you were at Wuhan, right?
Hmm?
Where at Wuhan when you were in China?
No, I don't know.
I know how in Wuhan. That is just a one general which just treatment all the just all the good years.
Don't say that.
Maybe 30 years, I don't know.
Yes.
But it seems so, meantime, and we have had personal conversations about this, that the whole story is now becoming more and more complex. Now we see 20 different subtypes in GIST. So we see primary mutations, secondary mutations. So we also know that in some countries, the level of mutational testing in primary mutations is quite low. Then we talk about new drugs with specific profiles. We talk about therapy and side effects. So the whole the story, or we just talk about surgery, so the story is getting more complex. What does this mean at the end of the day for the quality of treatment for the patients? Is it not necessary to change the whole system, how we treat these patients? Because otherwise, the patients, that's my I'm really afraid of this, that these patients are not treated sufficiently enough when they come to our hospital.
Yeah, unfortunately, that's absolutely correct. The problem is that over the years it was created the feeling that GIST treatment is absolutely simple. You take a prescription, you write imatinib, you hand it over, never see the patient again, and think that solves the problem. So in the beginning, the overall treatment was very poor. Then we had a very nice learning curve, but the complexity of GIST also substantially increased. And we currently, that's what I fear to be the case, have a situation that the curves cross again. So the complexity curves cuts the learning curve. So the complexity now is bigger than has been achieved by the learning curve. This means that GIST treatment quality will decrease if we don't counteract, and counteracting can only mean patients need to be treated at least in the context of a specially experienced team. Not exclusively by a specially experienced team, but in the context of a specially experienced team. If that is not the case, we will have inferior results. We recently had a patient with a huge gastric GIST. She would have required a total gastrectomy. And the mutational finding done by NGS and a big 3-page printout was no activating mutation, so-called wild type. And I told the patient 2 things. One, if this result would be true, unfortunately, you will lose your stomach. But I don't believe it. And a wild type diagnosis, I only accept by one single person in Germany. So I told the patient, we do not believe this so-called wild type finding unless Eva Wadelmann confirms it. So I told the patient, don't go to your surgeon. We wait for the secondary test in Münster. Eva did the test. sent me an email. I received the tissue. I'm sure it will be an exon 11. I told her that's what I expect as well. And a week or so later, it was confirmed classical exon 11 mutation. So this patient, if she would not have seen me for a second opinion, she would have lost her stomach. And that is a problem, living without a stomach. You don't feel real good. And it was a NGS, again, three pages, very complex, a lot of bullshit on it. Yeah, and that's the problem. So if you don't have the experience of 20, 25 nearly years, you get this and say, I don't believe it.
Yeah, but I think the problem is, of course, for you as patients, you feel now really bad because you don't know whether your doctor is one of the ones or the others. So if it's an expert or not, and how to recognize them. This is really an issue. I think it's then an issue when you've got some extraordinary thing. And as you know now already a lot about GIST, you know that, for example, the diagnosis of a wild-type GIST is exceptional and should always be checked for a second time by another laboratory. It must be me, but there are also in all countries people are experts in that, and if they double check, then you have a big chance that it's found. As I mentioned already, I said the long deletions in KIT exon 11 they are missed by NGS, and this is it's a classical case where you say already from listening, the patient wrote me an email and told me that she had the consideration to send me the blog, and if it's possible, I said yes, please go ahead. And I knew from the email already it would be an exon 11. And of course, this is horrible to imagine that other people, other doctors don't know that, but it's the truth. Yeah.
Advising our patients to get a second opinion, signposting them to the correct people who we know from our experience are experts.
And the issue is that it's not to be mean against the other doctors or to say they're too stupid. It's just that you cannot be on the same level, be experienced in every single tumor entity. And of course, you're right, Markus. The more subtypes we create, the more difficult it gets, and the less people are still able to handle all that bullshit. So we have to also to make clear what is just research or personal interest, and what is the minimum requirement a GIST patient has to have to be sure that everything went well.
Getting more complex because of them.
Yeah.
Yeah, and the numbers, the numbers in the newly defined subgroups are getting smaller and smaller. So if you see 2 GIST patients a year, it's very unlikely that you will see the rare subtypes. If you see 200 GIST patients, it's very likely that even if it's only 1%, statistically you will see 2. And the other doctor seeing 2 a year will need 50 years to see 1. Yeah.
Coming in.
No, we make it like what's Dolly with no.
Just a final statement. Very clearly, in any situation where a substantial decision has to be made, never accept a recommendation without an experienced second opinion. For a trivial decision, can I stop imatinib for a weekend because I want to go and so on and so on? That's a different story. But before you get your stomach taken out, before you undergo substantial surgery, before you change drug A to B to C, see an expert. That is essential.